Hi, I'm Rhoda Olkin, and my talk today is on Rethinking Disability Research, moving the field forward, and by field I'm talking about mental health. So there are 4 learning objectives, which I'm not going to read. So what kind of existing research is there? Well, there are just thousands of studies on explicit bias towards disability. There are fewer studies on changing explicit attitudes towards disability, and most of those are on children. There are even fewer on implicit bias toward disability, though almost all of them show negative attitudes, and just 2 studies that I could find on changing implicit attitudes towards disability. So where are we now? The real positive is that there have been important legislative advances starting in 1975 with the Rehab Act and the Individuals with Disabilities Education Act, and then in 1990 with the ADA, Americans with Disabilities Act. The field of rehabilitation psychology has moved from a medical model to the social model of disability. And there's much more visibility to disability pride and a disability community. But there are also a number of negatives. Despite thousands of studies on attitudes towards disability, almost none are on mental health professionals. Despite the laws, there's been no change to the unemployment data for people with significant disabilities. And although explicit bias shows very slight improvement, implicit bias has not changed. And in fact, there's very little and sometimes even a negative correlation between the explicit and implicit bias regarding disability. Another negative is that mental health professionals receive very little training in disability. And there are only 2 studies on the experiences of disabled clients in psychotherapy. Neither of them have been published yet, but I give you the references or the names in case you want to look out for those. So as I said, there's little or even negative correlation between implicit and explicit bias related to disability. So a study in the US of changes in implicit and explicit bias over a 10-year period found that there were changes for some of the other groups, such as people with a various sexual orientation, for race, for skin tone. But the implicit bias towards disability was stable over that time, and the weakest correlation between implicit and explicit bias was found for disability and for age. So what do we know about attitudes towards disability? Well, the stereotype content model posits that perceptions of groups are based on dimensions of warmth and competence, high and low warmth, high and low competence. So groups that are perceived as high in warmth but low in competence, which is how people with disabilities are usually seen, elicit pity and sympathy. So to plant a seed, when we try to make interventions in implicit bias, one of the things we might want to measure in our outcome data are there changes to pity or sympathy? A number of issues. One is that there are APA guidelines on the treatment and assessment of clients with disabilities, but these are not used for the most part in training programs. Diversity courses give very little time to disability, and knowledge about disability and attitude change may not translate into clinical skills. This is something I've noticed in my own classes, is that although my students often will talk about profound changes in their perceptions of disability, when I ask them very specific questions or give them vignettes, I'm not seeing those changes reflected in knowledge about how to approach clients with disabilities. Another issue is that individual attitude change is very slow. We really need broader systemic changes. Changes that are implemented, for example, in every APA-accredited clinical or counseling psychology program. And a key goal should be a focus on implicit attitudes because of this imperfect correlation between implicit and explicit bias. And our outcome measures should really focus on behaviors and particularly on clinical skills. So what do we need? Well, clinicians need relevant disability-specific knowledge. They need culturally appropriate skills, such as disability affirmative therapy. And they need management of negative countertransference, given that most implicit bias towards disability is negative. Supervisors likewise need relevant disability-specific knowledge. They also need to know how to best support their trainees with disabilities and to know how to help all their general trainees with their own negative countertransference towards disability. So, research. What does this mean for research? First of all, we should know how to ask people about disabilities. This is important because depending on how the question is phrased, we see that certain cultural groups are less likely to self-disclose. So for example, if you ask it in terms of, are you a person with a disability as defined by the Americans with Disabilities Act, we have some clear evidence that that is going to undercount Latinx population. So the way in which we ask about disabilities is important in our research. Then secondly, how should we think about those disabilities? Should we categorize by the type of disability like MS, or should we categorize by the functioning, such as people who use wheelchairs for a variety of different reasons? Then we need to think about how do we make our research methods accessible to disabled participants? And how do we format surveys, if we do online research, to be accessible to those with visual impairments? How might we modify our methods in our research studies so that it could include people with intellectual disabilities or traumatic brain injuries? How do we assess attitudes towards disability and models of disability, the moral model, the medical model, the social model? There are still not really good measures for this. And we must assess both short-term and long-term outcomes of interventions with our students when we teach them about disability. Then, of course, we have to assess whether our interventions with those students translate into behaviors with clients with disabilities. So how can research help? Well, we need to understand the best teaching methods for working with disabled clients. How do we help general mental health trainees learn how to work best with disabled clients? And what interventions do we use with them, with the students, that do translate into skills? Then, how do we ensure equal opportunities for mental health graduate programs, practica, and internships for the students with disabilities? Third, how can we change implicit bias on a much more societal and global scale? How do we reduce microaggressions towards disabled people, which occur at a very high rate? How do we go from compliance with laws in the strict sense of the word to really full inclusion of our students with disabilities and our clients with disabilities into society? And importantly, how can psychology be a leader in disability studies rather than trailing behind? Disability studies really started in sociology and history and then expanded to English, anthropology, medical anthropology, and psychology is really a very latecomer to disability studies. So, a long time ago, Harold Euchre made recommendations on steps we could take towards changing attitudes towards disability. He recommended 8 things. Cease using univariate approaches to studying attitudes towards disability. Be sure to examine both positive and negative attitudes. Most studies on attitudes look at only the negative attitudes. We should also investigate the sources of those attitudes, like what is the culture, the experiences, the teachings, the intrapsychic variables that go into someone's attitudes towards disability. He suggested developing better measures of attitudes towards disability, something that's still very much needed. And we should pay special attention to professionals and peers who interact with people with disabilities. We know that when there's a hierarchy, like a doctor and a patient, or a therapist and a client, that is not likely to change attitudes towards disability. To change the attitudes, you generally need 2 people at a peer level. We need to evaluate both the short and the long-term changes affected by multidimensional programs designed specifically to change implicit bias, and to study the very complex relationship between attitudes and behavior towards people with disabilities. Disappointingly, attitudes and behavior have very small amounts of correlation. And then we have to start putting the disability in the context of the entire person, of which disability is only one part. So, what's a research agenda that I'm recommending? Well, 3 particular things from Euchre stand out to me. One is to develop better measures of attitudes towards disability. There are now a number of such measures. Nobody is very happy with any of them. They each have their pros and cons. The benefit of using Euchre's measure, he has a measure called Attitudes Towards Disability, is that the most studies that have been done on attitudes do use the Euchre scale, and so you have lots of different other studies you can compare your results to. But we need to start moving towards better measures. Secondly, paying specific attention and special attention to professionals and peers who interact with people with disabilities, notably our trainees who are going to work with clients with disabilities, which is virtually all of our trainees, because the rate of disability in the population is 1 in 5. Then third, to put disability in the context of the entire person. So most studies that are done on disability focus on disability, and then studies that don't focus on disability don't include disability as a part of the demographic data. So I want to add to Euchre a research agenda. First of all, we should include our disabled students in the research process. That's going to be the best way of really ensuring, first, that they have access to research, but also that we are asking the right questions, doing the right kinds of methodologies, and thinking about disability from an insider perspective in the analyses. Second, to develop means of affecting implicit bias among graduate clinical psych students. Third, we should assess models of disability. I have used several measures of assessing models of disability in students' dissertations. There is at present no perfect way of assessing this. I'd like to see a better method of assessing models of disability, because models are turning out to be important in outcome data. For example, a research study that shows that people with MS who ascribe to the social model have less depression and anxiety than people who mostly ascribe to the moral or medical model. And then we have to assess our outcomes of our teaching in both the short term and the long term when we teach about disability. So one really important question is if we can affect attitudes about disabilities across the different types of disabilities, or do we have to address the differences across disabilities? And one of the reasons this is an important question is we know from numerous studies that there's a very stable hierarchy of acceptability of disabilities. That is, some disabilities are more discriminated against or more stigmatized than others. And so if we try to affect attitudes towards something high on the acceptability level, will it generalize to those lower? And if we try to affect attitudes towards something lower, will it generalize up to those that are less stigmatized? When we assess outcomes, we have to make choices about what we're going to assess. So as I mentioned, we might want to assess pity and sympathy, but also how comfortable do people feel approaching a client with a disability? What are their nonverbal behaviors, micro behaviors in the session that show approachability or avoidance? What are the long-term outcomes and how do we measure those? And then do we see actual skills in their ability to relate to clients with disabilities? We need to figure out how to debrief after we do our teachings with our trainees. Do we simply have class discussions? Are there particular things we need to bring out in those discussions? What's the best method of debriefing? I mentioned here 4 different existing measures. There's the attitudes towards disabled persons scale by Euchre. There's the World Health Organization has a measure. There's something called the social distance scale that has been used. And then, of course, there's the implicit attitude scales at Harvard University. So moving forward, first of all, we need to include disability status in the demographic data collected in all studies. We would know so much more about people with disabilities if we had data in all studies that included people with disabilities, but we don't. Then we need to make our research methods for most studies accessible to those potential participants with disabilities. When we have a sufficient N of people with disabilities, we could do analysis of the data separately for disabled participants. When disability is the focus of a study, we need to collect other relevant data so that we don't misascribe everything to the disability. For example, were there hospitalizations, medical trauma, physical abuse, sexual abuse, pain, sleep deprivation? So those are things that are going to affect outcomes in our studies most likely, and it's not just about the disability, though some of these things are sequela of many disabilities. Then we need to understand when we can group across disabilities, like wheelchair users due to different impairments, and when do we need to be really disability specific. And 6th, we need to study intersectionality, researching disability in the context of other demographic variables. Most work on disability, most studies on disability make disability the focus, and although the demographics might list other variables, it's very rare that the data analysis is done for, say, by gender or by ethnic group or by sexual identity. I'm leaving you with 3 different references. One is about how to teach disability, which has practical activities for in-class or homework, and I would love to have those researched to find out which ones seem to have what kind of impact. Disability affirmative therapy, which I'm hoping becomes a model for the way in which we help our supervisees and trainees learn about working with clients with disabilities, and for help in how to make your own research accessible to people with different kinds of disabilities. I have an article, Making Research Accessible to Participants with Disabilities. I've put here on the last slide my email at school. I welcome any comments or follow-up or questions. Please feel free to contact me. Thank you very much.